All right, so today in this video we're going to be talking about prenatal assessment. So this is going to focus on some of the assessment methods and things that we do to assess women during the pregnancy. The first consideration that I want you to think about is these antepartum terminologies. So antepartum refers to during pregnancy. You'll hear several other words that we're going to talk about, and one of them here is on the slide. Intrapartum is during labor and delivery, and then postpartum is after labor and delivery. So you'll see those terms quite frequently, and we kind of split up the content here based on those. So currently we're in that antepartum. So what's going on during pregnancy with that woman, and what are we going to be doing to care for her during pregnancy? And then we'll move into those other time frames. This slide includes a lot of important terminology. I'm not going to take the time to read off definitions during this voiceover, but I encourage you to look at your textbook and look these words up and make sure that you know what they mean, as you will see them in case studies and potentially test questions and things like that, and it would be absolutely essential to know these terms. So the first thing we have to do is a thorough history. And when we're talking about client profile related to pregnancy, this is all of the history and information, and it tells us a lot of stuff. So a lot of this we're going to get at the first visit. So they've come in, that female's just found out she's pregnant, and we're going through a history to get some information on her. At subsequent visits for that pregnancy, you're not going to go into this level of detail, but this is very important. So in a lot of practices, the first visit for pregnancy is actually not with a provider, but with the registered nurse to collect all of this very thorough history. So this is definitely a nursing task that would be done. So some of the things you want to think about is information on the current and past pregnancy. So in order to figure out what the due date is, we have to think about when the last menstrual period was and whether it was a normal cycle or not. Sometimes women can get just a little bit of spotting at the time of implantation, and so we do have to ask questions on was it normal to differentiate if what they're telling us as a date for a last menstrual period was truly a period or was it potentially implantation, because that can change the pregnancy time frame by about 4 weeks. Are they having any problems since they've found out they were pregnant, or did they have any problems with a previous pregnancy with bleeding or cramping? Are they having any discomforts or anxieties related to the pregnancy? While not all pregnancies are planned, that can create some anxiety, but even sometimes planned pregnancies. Maybe a person went off birth control planning to get pregnant and it happened very, very quickly, and so they're very anxious, or they've had a loss in the past, so they're anxious. So getting information on how they're feeling about the pregnancy is important. GTPAL, so that's gravida, term pregnancies, preterm pregnancies, abortions, and living children. So this gives us information about how many pregnancies she's had, the gravida, how many term pregnancies have delivered, how many preterm pregnancies have delivered, how many elective or spontaneous abortions have occurred, and then how many living children are there. So with a quick glance, we can get an idea of what that prenatal history looks like for that person. So it tells us the pregnancy history, and if she's had any child losses, did she deliver preterm? Looking at that and collecting that and putting it in a very simple format gives us lots of information at a glance. Gynecologic history, since we're dealing with pregnancy, is also really important. So we're going to think about, is she up to date on any pap smears? Has she had any surgeries that might impact the pregnancy? Menarche, sexual history might be important as far as STIs, any infertility, any of those things that could potentially be of value and applicable to the current pregnancy. Current and past medical history. So medical history is clear. When we think about those changes in pregnancy and some of the things we mentioned that might put somebody at risk, we talked about already some thyroid things and some gestational diabetes and things like that. So we really want to know if there's any medical things that might impact this pregnancy. Cardiac would be another big one. If there's any cardiac considerations, that's going to be challenging for all of those cardiovascular adaptations to occur in the way that we anticipate during pregnancy. So it's very, very important. In addition, family medical history can be really, really important. So we're going to talk about some of the things family, maybe some, genetic risks or anything like that would be important to collect. And then also that genetic history from both sides. So when we think family medical history, genetic history, this, and you'll see at the bottom of the slide, it also says we need dad's stuff. We need the partner's history. So that family and genetic history on his side impacts the fetus as well. So we do need to get information from both sides if possible. And then always think about religious, cultural considerations. Are there any occupational risks that might be in place? And then social history is very, very important. So often in pregnancy, we see some socioeconomic factors that can contribute and cause some concerns during the pregnancy, whether it be from economics and paying for baby. How are they going to plan their plan for feeding baby, how they're going to care for baby, can they afford daycare, do they have insurance that's going to be able to cover baby after delivery? Lots of things we want to talk about that we can start planning for and making sure that all of those needs are going to be met by the time delivery occurs. So this just again gives a breakdown, and we're going to do some practice with this in class on how to work through these and come up with that quick abbreviation so that we know at a glance what the pregnancy history is for that female. Of note, and you can see in this example that we'll work through, multiples, twins or triplets, count as one pregnancy and one birth, but the living number of children in that L would change. So just as kind of a note here. So we're going to go through a couple of examples on a worksheet, but in this example that's here on the side, it's her third pregnancy, so the G is 3. She's had 3 pregnancies total. So she's currently pregnant, so we put a 3 by that G. She had 1 set of living twins that were born preterm. Okay, so we could put a 1 by the P because they were preterm. She's had 1 miscarriage, so we'll put a 1 under the abortion because that would be considered a spontaneous abortion. And then under the L, there's 2 because she has twins and they're both living. So she would be a G3, T0, P1, A1, L2. And if we look at that, we'll be able to really get some good information. And again, we're going to practice this a little bit more in class as well. Nagel's rule. So Nagel's rule tells us how to determine a due date. So once we get through some of that client history and that, we look at that LMP and we have to figure out when is this person due. So in the book, it's going to show you as subtract 3 months from the LMP, add 7 days, and add a year. I also like just adding 9 months and 7 days. So plus 9 and plus 7. It gets you the same result. So in this, if you had a patient whose last menstrual period was January 15th of 2018, the due date, if we added 9 months to January, we would get October. And if we added 7 days, we would get 22. So that due date would be 10/22 of 2018. If you have a due date that crosses into the next year, when you add 9 months, if it goes into the next year, you just need to make sure to change the year. So we'll practice with a couple other examples when we're in class. Often, if that last menstrual period is not accurate, then they would do an early ultrasound to determine dates, because we do really want to have some precise dating for a variety of reasons that we'll talk about as we go through the next several weeks. So when we get into a physical exam for pregnancy, there's really by body system, and you guys learned this in health assessment, most of it's very similar. There's not much that changes with exception of the abdominal and pelvic assessments that we're going to take into consideration. The rest is really very similar, with the addition of noting any pregnancy abnormalities or changes. So within the physical exam specific to pregnancy, with that uterine assessment, that fundal height, as we talked about in the previous voiceover, we measure from the symphysis pubis to the fundus of the uterus, and we're looking for patterns. Is there slow or fast growth? Is there a need for further evaluation related to what we're seeing in there? The McDonald method is the method that is measuring from the symphysis pubis to the top of the fundus. So everything's got to have a name, but we're looking over time. So you are seeing the patient at 32 weeks and you're bringing her back to the room to get her ready for the provider. You're going to look over time and see, is the uterine, the fundal height appropriate for where she's at? Is there a change, a decrease or increase substantially over where it's been? ranging. So there's some good information that can be obtained from that. There are some things, of course, stature and body habitus can impact that fundal height measurement, but again, it's really, really important to continue to do. We also assess fetal development. So we'll talk about quickening with the pregnant female. Has she felt the baby move? And generally that's around 16 to 20 weeks. Sometimes a little bit later with a first pregnancy, and sometimes maybe a little bit sooner with subsequent pregnancies. We also will assess the fetal heartbeat, so via Doppler, and we start around 10 to 12 weeks, and with the normal range noted from 110 to 160. Now, at 8 weeks, you could possibly Doppel the fetal heart tones. However, in practice, we usually start just a little bit later attempting to do so, because there's a variety of reasons would make it very challenging to hear it early on. The uterus is much smaller, it's down closer into the pelvis versus coming up into the abdomen. And it's very challenging sometimes in those, 8 to 10 weeks to hear via Doppler. And if we don't hear it, then we need to follow up. Even though it's very much can be a normal factor that we wouldn't be able to hear it, it maybe would require that ultrasound to follow up and ensure that the fetus is still viable. So we do tend to wait a little bit longer, and then that's going to happen at every visit. We always listen to that fetal heartbeat and listen to it for a little while to ensure that it's normal. Another fetal development thing that can be done is ultrasounds. So ultrasounds can be done to look for a variety of things. Early on, it would be done, we could do transabdominal or possibly transvisible, but via transabdominal, you can see amniotic sac at about 5 weeks. The heart activity begins to be noticeable in ultrasound by 6 or 7 weeks, and breathing by 10 to 11 weeks on ultrasound. So there's some key things you can note on ultrasound that are very evident. For dating purposes, in those pregnancies that we weren't sure about that last menstrual period, they date the pregnancies and early ultrasounds using a crown to rump measurement, and this is really accurate in the first 12 weeks. So uterine growth in that early time frames, or the fetal growth in those early time frames, is really consistent across all pregnancies for those early cellular divisions and multiplications. After a certain point, we start to use biparietal diameter, and that's measuring the head once we can visualize that adequately. And that's helpful till around 26 weeks. Once you get into that third trimester, it's very challenging to get accurate dating ultrasound accomplished. The baby's getting a lot bigger, it's a lot more crowded in there, much harder to have accurate measurements. And when we get into that third trimester, then we start to get into some of the genetic things. So, maybe this is just going to be a big baby because mom and dad were big babies, or maybe she tends to have smaller babies. And so some of those ranges can really impact the ability to date successfully later on in the pregnancy. So we really like, if possible, we want to date early on if we don't have a clear last menstrual period. Some of the things that would also be noted on pelvic exam, we talked about pelvic anatomy, is we would look at maybe pelvic adequacy. While we don't look at it 100% as we've talked about, it is something to kind of consider. Additionally, there is some labs, and what we're going to focus on with the labs is actually what's on the standardized form. So you'll all be getting a packet that represents a paper antepartum record. So although this is usually done in the computer these days, we're going to look at that. And within that packet, it talks about some of the normal labs that are done. So early in the pregnancy, we're looking at things like blood type, NRH type, hemoglobin and hematocrit, rubella, and then the screen for syphilis, which is the VDRL or RPR. We might do a urine culture, and then we're also looking for hepatitis B antibodies and HIV testing. So of all of these, we're looking for things that could be risk factors for the infant. So the blood type is very important, and we're going to talk about why we need to know that later as we go through this antepartum care unit. Hemoglobin and hematocrit, because we want to kind of measure that. We need some baseline data. We want to see if there's any anemia of pregnancy occurring. And then when we look at rubella can be very detrimental to an infant. So we want to know if the mother's immune. So we're going to do that rubella titer to see if there's any concerns. If it is negative, we would give that vaccine after delivery, not during the pregnancy, because it's a live vaccine. The VDRL, or screening for syphilis, is because of that congenital syphilis risk, as well as hepatitis B transmission. We want to see that she's got the antibodies, and then HIV, because again, we want to decrease transmission of certain considerations. So those are some common ones. We repeat some of these later in the pregnancy. And then we also do, around 28 weeks, we do a diabetes screen, and we're going to talk about that some more later on. So there's some key things that we're going to do. We'll do group B strep later in the pregnancy, which is a vaginal culture. So lots of labs that are done, and you can see those on that antepartum record, and those are pretty standard across all providers because they're ACOG recommendations. As well, we do a urine dip at every visit to look for protein and glucose. So glucose, while it could be physiologic, could also indicate gestational diabetes. And protein in the urine is a sign that's indicative of preeclampsia. So that's a really quick assessment. We have every woman just give us a sample at every visit, and we check that. So that kind of gets in a little bit to those subsequent histories and assessments as well. So what are we doing at each visit? So that first visit, we did a lot of history tape. We did a lot of information to fill out those first several pages on this form. At subsequent visits, we're going to be doing things like that fundal height every time. Do we know what position baby's in? What's the fetal heart rate? Does mom feel movement? Are there any signs of preterm labor? Potentially the provider might do an exam, a cervical exam, although there's few of those. The nurse will check the blood pressure every time because we're going to be monitoring that. Early in the pregnancy, we anticipate as that blood volume increases that the blood pressure will decrease under the influence of progesterone. We'll see, and then we want to monitor to see if it goes up later in pregnancy. Is there any edema or swelling that could occur with that water retention that happens? What's the weight? Is the weight gain following a normal pattern for what we would anticipate based on the pre-pregnancy BMI? And then that urine for the glucose and protein. So those are several key things that are checked at every visit. Easy things to monitor and do, and then there's some additional assessments that may be indicated as the pregnancy progresses. So nursing interventions. What are you going to be doing as a nurse? So obviously, a lot of what we talk about is education. So prenatal education. What can they expect in childbirth? What are some of the risks that might happen? And not just for the parents. You might also be considering the siblings, the grandparents, the fathers, some different things. So we know that in labor, fear increases pain, which increases tension, which increases fear. And the cycle can continue to go around. But we can kind of reduce that fear because often it's fear of the unknown. So we can try to alleviate some of that through education of childbirth and what's going to be happening. And historically, we picture these classes and we think about breathing. But in reality, these classes do a lot more than just talking about breathing. Breathing is really important in labor to prevent hyperventilation, but we also really want the mom to know what to expect, what's going to happen when I go into labor, what are some of the things. Tour the unit, get comfortable and familiar with the process as much as possible. Other information the nurse might educate would be on medication classifications. So a lot of providers will provide a list of over-the-counter medications for the parents on what's safe to take during pregnancy. And that would be somewhat collaborative with the provider. Talking about substance use, so tobacco and some of the risks that might be associated with. So we know that tobacco use in pregnancy can lead to low birth weight, preterm premature deliveries, fetal demises or losses. It also increases the risk of SIDS, upper respiratory infections, and ear infections in the newborn and infants. So some key things that we would be educating on. In addition, there's several common discomforts, and those are listed on a handout that you're going to receive. And those, we're going to be talking about what can we do to suggest some relief for those discomforts. So nausea, vomiting, urinary frequency, and backache. So pay attention to that handout and think about what kind of education or interventions could you offer to this client based on some of those discomforts that we talked about on the previous voiceover. So this is all for this voiceover, and we will be moving into the next one here shortly. Thank you.